Good morning. Thank you for the opportunity to present. I have no disclosures. So obesity continues to be a growing problem in the United States. By 2014, more than a third of the population was deemed to be obese. And as previously mentioned, the adjustable gastric band had been an initially popular option for weight loss surgery in the early 2000s, but in the United States has subsequently declined in popularity. Approximately 40% of patients will undergo failure to lose adequate weight loss or failure to maintain adequate weight loss, and up to 20% will have band-related complications. Thus, these patients will seek conversion surgery in order to improve their outcome. And whether one type of conversion surgery is better or safer than the other still remains uncertain. And thus, we aim to assess the safety and efficacy of conversion Roux-en-Y gastric bypass compared to conversion sleeve gastrectomy after failed adjustable band. We performed a retrospective review at a single institution from August 2011 to December 2014 and looked at 64 patients who underwent a conversion Roux and 17 patients who underwent a conversion sleeve after failed gastric band. All surgeries were performed laparoscopically by 8 surgeons with 1 conversion to open. 14% of patients who underwent a conversion Roux did so through a 2-stage procedure, and 29% who underwent a conversion sleeve did so through a 2-stage procedure. In order to assess efficacy, we performed a sub-analysis on patients who received a conversion Roux or a conversion sleeve for primary weight loss failure, and this yielded 46 patients in the Roux group and 11 patients in the sleeve group. Our primary outcome was a safety outcome. We looked at in-hospital and 30-day mortality and major morbidity. And our secondary outcome was an efficacy outcome, and we looked at weight loss at 1 year and improvement in antihypertensive and anti-diabetic medications for patients who underwent conversion surgery for primary weight loss failure. Continuous variables were analyzed with t-tests and Wilcoxon tests, and categorical variables were analyzed with chi-squared and Fisher's exact tests where appropriate. So the average length of time between the band and a conversion Roux was about 4 years, and the average length of time between the band and the sleeve was about 4.7 years. For both cohorts, the primary reason for conversion surgery was weight loss failure, with only about 10% undergoing conversion surgery due to complications alone. So to assess safety, we looked at the entire cohort. Baseline characteristics are pretty similar between the conversion Roux and the conversion sleeve. Age was about 47 years, primarily Caucasian. Pre-conversion BMI was about 44. About 25% of patients had diabetes, and about 50% of patients had hypertension. The only difference in terms of baseline characteristics was that the Roux group had a higher proportion of patients who were women. In terms of 30-day outcomes, statistically, both groups had comparable in-hospital and 30-day mortality and morbidity. We did notice that there were a higher number of complications in the Roux group. There were 3 reoperations, 1 for a GJ stenosis, 1 for bleeding, and 1 for small bowel obstruction. There were 6 readmissions in this group, 4 for poor oral intake, 1 for the small bowel obstruction, and 1 for cellulitis. Median length of stay were pretty much the same for both groups, about 2 days, and there was no mortality, pulmonary embolism, or leak out to 30 days. So to assess efficacy, we looked at patients who underwent conversion surgery due to primary weight loss failure, and again, baseline characteristics were similar between both groups. Baseline BMI was about 44 units for both groups. Average hypertension rates were about 60%, and diabetes was about 25% for both groups. So both groups showed a consistent decline in their BMI out to 1 year, and within group analyses showed that there was a statistically significant decrease in BMI as early as 30 days that continued out to 1 year. And by 1 year, on average, between both groups, patients lost about 10 units in terms of BMI. Now, to compare between groups, we did a between group analyses, and we looked at weight loss at 30 days, 6 months, and 1 year, and we showed that at each time point, weight loss was similar between both groups. At 6 months, average BMI was about 36 in both groups, We had percent excess weight loss, about 48 in the Ru group and 35 in the sleeve group, and this was not statistically significant in terms of their difference. And at 1 year, average BMI was about 35, with 56% excess weight loss in the Ru group and 38% in the sleeve group. Again, not statistically different. So in terms of comorbidity resolution, we looked at patients who underwent a conversion Ru, who carried a diagnosis of hypertension, and who had 1 year follow-up. And we found that in the Ru group, there was a significant decline or decrease in hypertension medications from an average of 1.6 medications per patient to an average of 1 medication per patient. And 33% of patients had complete remission of their hypertension, and 21% of patients had an improvement in their hypertension by a decrease in their medication. And in the sleeve group, we didn't see a significant decrease or change in terms of hypertension, and this is probably primarily due to a fairly small sample size. And in terms of diabetes, for the Ru group, 43% had complete remission at 1 year and 14% had improvement. And in the sleeve group, 33% had remission of their diabetes at 1 year. Neither of these turned out to be statistically significant, also likely due to a small sample size. So there are limitations to our study. It's a retrospective analysis, so there's always inherent selection bias. We are limited by a small sample size, and we also included both single and two-stage procedures. So we conclude that both conversion Ru and conversion sleeve are safe procedures, and when performed for weight loss failure, both surgeries resulted in similar weight loss success. Thank you.